So when we were talking about heavy metals earlier, and I had the one case that I showed you that the mercury and the lead were high together, it's not uncommon for you to do heavy metal testing and the lead is really high and the mercury is not so high. And then they think, well, I don't really have mercury as an issue, I just have lead, and lead's not in my fillings, so I'm going to leave my fillings. Let me tell you, it is my experience, as you start the chelation process and you move the lead out of the body, now the mercury starts being able to come out. So I always prepare them. I say, look, it's not going to, matter of fact, it's going to surprise me if it doesn't happen this way. But as the lead starts coming down, you're going to see your mercury level go up because it's being discarded in the tissues, because now we can reach into the body and get it out. So you want to make sure that they understand that as well, so they don't think that you're giving them mercury poisoning in all of this process. Okay, there's another test, the test, that can be done with blood, hair, and urine. I still personally like the other because I feel like I get more information the way that I do it, but I just want to let you know there are other tests that are out there. There's a urinary porphyrin test that can be done as well to give you markers for heavy metals. When we were talking earlier about the intracellular versus the extracellular, this is where anything, vitamin C will move heavy metals out from the inside of the cell into the extracellular space. It's mopping that up that becomes important. And so you want to use something like chlorella, but I'm going to preface that by saying some chlorella actually has mercury in it. So you have to be careful about where your source is. Yeah, Amara's. There's a couple of them out there. Okay, so when not to remove mercury? Well, obviously when the dentist is not trained in safe mercury removal. I remember the first time I taught a group of physicians, and later one of the people contacted me and he had gotten so sick that he couldn't practice because he had someone take out his amalgams that didn't follow any protocols whatsoever. So was he a hoarder? Probably. And that's just not a smart thing to do. When a woman is pregnant, not the ideal time to have mercury removed. Does it mean that we would never do it? It'd have to be an extenuating circumstance. The filling broke and the tooth broke and the tooth is salvageable, then we would probably go through precautions. When a woman is breastfeeding, same thing. It's not ideal. I have them pump and dump if they have to go through some kind of amalgam. This is not the time where you do an entire revision. But if there were one tooth that had to be addressed, then I would just have them simply pump and dump. Now, testing the dental materials themselves. There are all these materials that we're about to expose the person to. The anesthetics, the filling materials, the bonding materials. You're looking at using bone augmentation in some cases. Orthodontic materials. Everything in dentistry is foreign. There's absolutely nothing as good as what God gave you. And so what I don't want to do is have this person undergo a dental revision where they're having a known neurotoxin, mercury, taken out of their body, and then have something placed that they have some kind of a reaction to. I mean, this is what I'm envisioning in my mind. Somebody goes in and they get their fillings taken out by a proper protocol, but then they have something placed and they start having headaches. 3 months later, they're at their primary care saying, I've been having headaches for months now and I don't get it. Ibuprofen, Tylenol, sinus pills, I've tried everything and I still have this nagging headache that's here. Their primary care is probably not going to say, oh gosh, did you just have some dental work done? Do you think that you could be reacting to that material? No, so they're going to draw labs and see if they have anemia, because that might be a reason for their headaches. And then they don't find anything, so they go, wow, I hear you that you're having these headaches. So I tell you, let's do a CT or an MRI to make sure you don't have brain cancer. And then the report comes back and they can't find anything wrong with you whatsoever. So they say, I really want to help you out here. How about I just put you on Neurontin for the rest of your life? Really? You'd like to find the underlying cause. So some of these people are very sensitive. They come in, they have high levels of candida, which is making them overreact to every kind of smell possible, which is why a fragrance-free office is a good, safe place for them to be. But I think that everybody needs to go through compatibility testing. When you're looking at the common thing that I hear, well, why don't you do this metal crown because it will last a lifetime? Oh, I just hate that answer. I would rather you outlive your dental work and have to have something replaced than for it to cause you to be in a coffin earlier because it was a more durable material. So I still would just like for people to get tested, especially those, canaries that come in and you know who they are. So there are different ways to do compatibility testing. One of them is through blood serum compatibility. And you're going to see at the vendors when you go talk to them tomorrow, there are a couple of vending companies that provide that service for you. So if you don't have someone who does EAV or muscle testing, this is at least a way for you to get an idea about the blood testing and what that person might be compatible with. What they do is they take the sample of blood. Now, here's a couple of kinks. When I do food allergy testing, I make sure that my patient has not had any steroids for at least 6 months. Nothing. Not a nose spray, not an eye drop, not a cortisone cream, absolutely nothing, because that compromises your immune system and tells it to chill out, right? I also give them a list of all of the foods that are going to be tested because there's about 96 foods in the testing that I do. If you eat something that you're reactive to, you have about 30 days of the antibodies at least being heightened enough that you'll be able to see them on blood testing. So if my first food allergy testing comes back that the person is really reactive to gluten and they are gluten-free, their next test should come back and it really doesn't see a reaction. Why? Because I don't see antibodies because they've not been exposed to it. So my question when doing blood testing for allergies to dental materials, did you ask the person if they'd taken any steroids? These people have not been subjected to 1,700 different dental materials that are out there, all these chemicals. So how does the report come back? It comes back S or NS. Comes back satisfactory or not satisfactory. The satisfactory means that that non-satisfactory means that they found an antibody with that material, so it shouldn't be used. The satisfactory means that they didn't find an antibody. So now I'm going to stretch my story a little. Your patient has lived in Russia all their life. They've never had a strawberry in their life. Are they allergic to strawberries? You don't know. Is it going to show up in the test that they're allergic to strawberries? No. It will come back S. So now the S doesn't mean satisfactory. The S means you didn't react. It's a question mark. So there are other tests that are available. One of them is a Melissa test that does look at a deeper level. One of them is, those are the two companies that you will see downstairs tomorrow. Here's the Melissa test. Oh gosh, it's not that one. Oh, okay, let's go with this. It's a good analogy. Okay, so my person comes in and I'm doing testing on them with EAV. And they're gluten sensitive. It's going to show up. It's going to kick it out of the system. You do muscle testing, it's going to kick it out of the system. How many people do you know that have gone to their doctor with all the correct symptoms for celiacs or gluten sensitivity, but when they do testing, they don't show up allergic to it? It's like they just made it up in their head that they have gastrointestinal problems? No, they're reactive to it, but they're reactive at an energetic level. That's pretty woo-woo-y, I get that. But those people, when you slip some type of gluten into their food, they really have all those symptoms. Mike, is that you? So that's where the difference between energetic testing might be an advantage to you, either doing EAV or applied kinesiology. So is there anyone here who doesn't know what applied kinesiology is? They don't know what muscle testing is. Everybody's seen somebody do muscle testing before. If you've not and you're too embarrassed to say anything, please come up to me afterwards and say, hey, talk to me a little bit more about the muscle testing. There are some great classes that you can take to learn how to do this. But anyway, downside for me is you just get a yes or a no. You don't get a how yes, how perfect is this versus a how no is this. When you're using something like electrodermal screening, you get a whole bunch of yeses, but you actually have a number value. So I'm just going to, for simplicity, if I take a baseline reading on someone on a point for allergy, and that baseline is 50, then what I'm doing is challenging them against all the other dental materials. And ideal is anything that shows up 50. It means it doesn't take the body out of balance any. If something came back a 49 or a 51, it would be equally challenging to the body, off by 1 point. Then a 48 and a 52 and a 47 and a 53, and I stop at about a 5-point spread, and I won't go any further than there. Those materials are not good. So if I've got 4 different anesthetics and only one of them is a 50, the 50 is the one I'd like to choose. But if I can't use that for whatever reason, like it's not long acting enough, use that as a rationale here, then I would start looking for something that's a 49 or a 51. Then I'd go to a 52 and a 48. So do you see that I'm able to look at the goods and find the better of the goods and the worser, that's not a word, worse of the goods? And then the same thing with the bads. You know, look at it and go, oh my gosh, there's no way I'd ever use that. It just takes you so far out of balance. So that's one of the reasons why I like the energetics. You know, for me, this is the part of the woo-woo-y that I kind of discarded in the beginning. I said, no, I'm so conventionally trained that this is just too eclectic for me. I can't go there. But as time has gone by, it's proven itself over and over again. So I am standing here before you going, okay, this is true science, as weird as it sounds. I believe that I can pray for somebody and it elicits a response. I believe that with my whole heart. I do believe that there are certain people that you feel the energy sucked out of you when they come in for an appointment. And when you see their name on the schedule, you go, oh my God, no, not her. You don't even want to say their name because you're fearful that the universe will make her pick up the phone and schedule an appointment. I don't get how all that works, but it has something to do with energy, and so now I am really much more in tune with those energetic mismatches. So some people will put on a wristwatch and it will stop. They take the watch off and it starts again. Now, how do you explain that? I mean, I can't, but I have a couple patients that are just that odd that it works that way. For me, there's a particular piece of jewelry that I absolutely adore, but when I wear it, I don't feel good, so intuitively I come home and I take it off, but I paid too much money to get rid of it. So it's still my jewelry, but I just don't wear it very often. So those are things that are energetic mismatches. Can the person become compatible with things that they're sensitive to and vice versa? Absolutely. I have them sign a waiver that says that based on your health right now, this is what you're able to tolerate. Just like with foods. Somebody who is healthy now and later gets candida at sky-high levels, they're not going to be able to tolerate what they are able to tolerate at this moment. Vice versa, if they come in and they've got high levels of candida and they can't tolerate anything, and they get healthier and you get the heavy metals out and you get the candida levels under control, they are able to tolerate much more than what they're able to tolerate at that moment in time. So you're not duty bound that this is going to stay this way. But I have had people that have come in and I've done testing on it and I've not been able to find anything other than a temporary material that they're okay with. So I, in that instance, had this particular lady have her revision done and they went into temporaries. Sent her off to an MD who worked with her for a couple of years on her candida levels and a lot of other problems that she had. Once she started getting cleaned up, she came back and she was able to tolerate a lot more. So we went into more permanent restorations. And what was interesting is this has been like a 10-year process of me seeing her off and on. And I've done compatibility testing or allergy testing on her for dental materials more than I've done on anybody, and she has gradually become okay with more and more things. This last time she came in wearing the strongest perfume. I thought I was going to die. And this is someone who wouldn't even drive a new car because the smell of new cars just sent her off the edge. This is somebody that was living in a tent in her backyard because she could not stand to be around the smells of her family. So to just show you the difference of where she is now is absolutely amazing. Okay, so there's all kinds of different things that create problems for you. You can get away from people like the person that I know everybody has in their practice that I don't want in mine because I have my own. But those types of people you can get away from. Dentistry, when it goes in your mouth, is a 24-hour-a-day exposure. You can't get away from it. It's like the gluten-sensitive person who is just living in a gluten factory all day long. You're just not going to expect to get any better. So those really canary-type individuals, the best thing you could do is make sure that they get compatibility testing.
Okay, the next area of concern is the subject of root canals. Can root canals really be the source of health problems? Right now, one of the current things in research is the study of biofilms, and we're being directed there to being links between biofilms and cardiovascular disease. Secondary infections can set up any place in the body. A root canal tooth is a dead tooth. It's had any nerves and blood vessels removed from it. Energy cannot go through the dead tissue. A root canal is not overwhelming for everyone, but for some it is, and it is definitely a burden which becomes cumulative. So basically, we've got the structure of the tooth, and in the root canal tooth, the living material, which is easily apparent in the pulp and the canals, is obliterated and removed. The blood vessels connect through the apical foramina, and it is there that you get the nidus for infections. Generally speaking, in a root canal tooth, the only thing that can be cleansed are the major canals, because we've got miles and miles of minor canals that can never be cleansed, nor the lateral canals that come out through the periodontal ligament as well. So in performing a root canal, files are put in the teeth right to the apex, and then they're pulled back. The material is debrided out, and that's what you're left with. Gutta percha is packed into the tooth with a master cone which goes to the apex. You're wearing gloves? That's good. Somebody said they're wearing gloves. So there you've got the dentinal tubules, which Dawn was just addressing. This is a scanning electron microscope visualization of it, and you see the length of them, the little latchings on the sides. Again, you cannot clean them. It's important to take x-rays of every root canal tooth. That's a periapical. The patient may not complain of any pain, but sometimes you can readily see evidence of the infection, as in here. And that's some bone loss there. Another one, some root resorption going on, plus a periapical infection. So the body is actually, in this example, trying to get rid of the tooth. And this is, this tooth has been lasered 3 weeks prior to being tested. And you see the inhibition of certain enzymes. So the phosphoryl kinase is inhibited 53%. Phosphoryl is A 52%. And then that leads on to the measure of toxicity, and that's all severe. This is a tooth which was lasered 6 months prior to being tested, and the enzymes which were assayed, the levels were even higher, leading to extreme toxicity levels of these teeth, of 5s. And that included phosphoryl kinase, phosphorylase A, pyruvate kinase, creatinine kinase, and adenylate kinase. Then we've got oral foci and cancer links. P53 is known as an oncogene, and it's a tumor suppressant. P21 controls replication rates, and CDK2 controls the cell size. 4,000 samples were taken from cavitation sites, and 900 root canal teeth were tested. They had to wash these teeth 3 times because the toxins were so strong. So they had to dilute them 8,000 times in those 3 washings just to register. Toxins from the root canals totally inhibited P53 by 99%, P21 by 68%, and CDK2 by 67%. And then the toxins from the cavitations inhibited all 3 of these by 99%. The effect of P21 was overstimulation of cells like autoimmune cells, and links were found to ALS, MS, lupus, and Parkinsonism. Beta-tubulin is destroyed by the toxins in the root canals, and cavitations 5 times faster than mercury does, just from the toxins. Yeah, so it's pretty scary, the good things that dentists do with extractions and not extracting the teeth properly, and root canals. In doing the extractions properly, it's removing the cortical plate so that you can get proper blood flow and get bone fill rather than osteonecrotic lesions forming.
I'm going to sometime during this presentation switch to some things. At lunch today, I was sitting with John and Edson and a few other people. They asked me some questions. I said, oh, that's too bad. I have it in another presentation. So I went to the other presentation, downloaded it on a drive, and put it on here. So I'll be adding some things that are not in your notes. If you need to get copies of it, you can contact Dawn or myself. My email is docdentistaz.com, doc@mydentistaz.com. So 2 commonly provided services we as dentists provide every day without regard of the future consequences to patients' health. I'm very lucky. I have some great sons. One of them is an oral surgeon. And one day we were in my office. My mother, when she was alive, came in and she had some root canals that had fallen apart on her lower left jaw. And she wanted them out. And I said, that'd be fine. And my son was there. So we're in this operatory. I'm sitting on the right. My son's left-handed. I'm right-handed. He's on the left. He's going to assist me. And my mom's in the middle. And I get her numb. We get ready to start the surgery. And she looks up, and I'm just picking up the scalpel. And she says, stop. I go, what's wrong? What's wrong? She says, wait a minute. I have my son on the right. I have my grandson on the left. And I'm the center of attention. What more could a Jewish mother ever ask for? So these things that we're doing, extractions, when a tooth is extracted, most dentists do not thoroughly decorticate the socket surface to remove the periodontal ligament. And if you look at the CPCT codes that are in the ADA, how you can charge out and get paid for your services, in a 7110 or a 7210, it will say something to the extent that, decorticate the surface or clean the surface of the socket. What they're talking about is taking a spoon and cleaning the side of the socket so you're burnishing the periodontal ligament into the bone. So what's the purpose of a periodontal ligament? 1, it holds the tooth to the jawbone. 2, it creates a cushion. So when you bite down, the tooth goes either up or down into the socket, And when you release, it lets go. And it's causing a pumping action. Then number 2 or 3 gives you your perception of balance and being able to chew properly and not bite too hard, etc. But the 4th purpose of all ligaments is it prevents bone growth. So if you keep that periodontal ligament within the socket, the capillaries can't get in. So if you've ever had the pleasure of going into the 3rd molar areas on the lower, the top bone is really thick. Well, why did that happen? Because the blood supply can go across the top and form a nice solid bone. But where the tooth was and the periodontal ligament was, does not get the capillary flow. And then you'll see holes in the jawbone. 3D combing shows that very well. Bone cannot grow through ligaments or the PDL. Consequently, the inner part of the socket cannot grow and the bone has incomplete healing, which may become a future site of a lesion. This becomes a site of bacteria and viruses to thrive since there's no food source or the ability of the body to protect itself and fight these organisms, that they not only survive, but they multiply. Yes? Not really, because what happens with primary teeth, the adult tooth will erupt and it dissolves the teeth or the bone that was there. So generally speaking, no, it won't cause a problem for primary teeth. Now, if you have no adult tooth underneath it, then I will decorticate the area. But most of the time, no. That was an excellent question. Root canal therapy, if there's a dumb question, don't worry, I won't tell you that it was dumb. But that was good. Root canal therapies provide service when the nerve of the tooth becomes necrotic and infected. The blood, nerves, and lymphatic supplies are removed. The inner part of the tooth pulp and canals are shaped and filled with the material to keep the infection out. But it also isolates the protein amino acids within the dental tubules, and they decay without food. Oxygen and water supply no longer exists, and no waste disposal pathways are available. But if you go into Grossman's literature, Grossman was like the father of endodontics later in the 30s. He said the tooth's support system was the periodontal ligament. It didn't matter if it was pulpless. I wonder, and he compares this to the skin. He says there's bacteria on the skin, we're alive, but the skin has a lot of functions in breathing. The inner part of that tooth is now embalmed. There's no activity going in there unless, because you have no hydrostatic pressure going out, the bacteria viruses come in, they have a party. Because they've got 3.5 miles of dental tubules in a molar tooth filled with protein that's decomposing. What more fun can a virus or bacteria have but to go in there and have a good time? So we got to recognize and diagnose. Few diseases represent such a subtle microscopic reflection of long-standing physiological phenomena as ischemic osteonecrosis. And few maxillary facial diseases are so difficult to diagnose and separate from the odontogenic inflammatory conditions. Well, I hate to say this, but when you look at this, and this was done by Dr. Jerry Boco, who's here this weekend, and John McMahon, Robert McMahon, who I had the pleasure to meet last summer. He's an oral surgeon that believes that these things need to be cleaned out. So the 2 most obvious and unique features of well-established systemic disease, the disintegration of marrow, bone marrow, or dry rot, and the neuropathic characteristic of accompanying pain. When Jerry first started with this pain of the mouth and face, 90 or 95% of the people he saw had weird facial pain. It wasn't until later, about 20 years later, he was seeing more 80% non-symptomatic. So NICO, which he termed, he says, well, it's not all NICO. It could just be ischemic osteonecrotic lesions. So recognizing and diagnosing ischemic bone disease, dentists for the most part are diagnosing simple conditions from an x-ray, such as cavity and abscess, draining fistula above a tooth. They're obvious. What happens when something's not so clear? In medicine, physicians give a few differential diagnoses when it could be a different possible condition. Let's face it. You look at an x-ray, you see a cavity. What do you got? A cavity. If you see an abscess, it's so obvious. What do you got? An abscess. But looking for ischemic osteonecrotic lesions, and I'm going to show you one or two on a 3D cone beam, it starts becoming obvious. What about ischemic osteonecrotic lesion, chronic fibrosing myelitis, bone marrow edema, condensing osteomyelitis, cancer? What are the possible solutions? Extractions, remove 1 to 2 millimeter of bone within a socket or past the extraction sites and remove the affected bone, being very careful around the third molar, mandibular third molar, so you don't cut a nerve. So that's the answer to your question. Clean the site up. If you were to give birth to a child and you do not clean everything out, you're going to have infection for the poor mother giving birth. That's why the afterbirth has to be clean. Same thing, just think of removing a tooth like delivering a baby. This allows the body to lay down new capillary beds, brings in the necessary functions to heal and grow new bone. Use of homeopathic remedies, ozone, early in the process to try to prevent the need for a root canal. I can't tell you how many people come into my office and I shoot it up with ozone 3 cc's at 32 concentration at the apex, but I always numb my patient. It hurts to get ozone. I came back from a conference, I was so excited, and I thought I had a problem in my mouth, so I injected 18. About 5 minutes later or so, I woke up. I was in so much pain. The needle was across the room. I passed out from the pain. So be careful. I have some patients that come in, and they come in from the East Coast, and they said, oh, I hate ozone injections. They're so painful. I said, well, didn't they numb you? You mean that's an option? So think about that. Extraction of tooth, bones, zirconium oxide implants. If the individual is compatible, many more possibilities for augmentum of a site. I'm using something called Steiner biotechnology. Steiner socket graft paste is a beta tricalcium phosphate. It's pretty cool. It grows your own bone. So if we do not know what is normal, how do we know what is, how do we know what is not? In an article by Hal Huggins, he did his DNA test. Now it's Dental Connections. Blanche Ruby is the owner of it. She's a sweetheart. There's a distinct predominant bacterial flora of a healthy mouth. It's highly diverse. It's important to fully define human microflora of a healthy oral cavity before we can understand the role of bacteria in oral disease. Hence, there are specific bacterial populations that are indicative of inflammation and disease, and it is so cool, depending on where they are found in the mouth and the rest of the body. Fusobacterium in the mouth isn't so bad, but when you get it in your intestines, you're looking at intestinal cancer. Where does it generate from? The oral cavity. There's so much literature out there today, and if you go back to New England Journal of Medicine, they talk about periodontal disease being terrible for your heart, being terrible for diabetes and everything else. But what about endodontics? Back in 2006, there were over 22 million root canals performed according to the American Dental Association in this country. If each root canal costs $1,000, do the math. $22 billion industry annually. Who wants to take them on and tell them that what they're doing could be harmful to a patient's health? Think about it. That's a lot of money. Lots and lots of money. Anyway, so you have to define what's normal. And Alan Sisk, dentists introduced many conditions of chronic oral facial pain as a major diagnosis and therapeutic problem. Chronic pain may involve the structures of the eyes, ears, nose, paranasal, jaw, neck, throat. Pain may not be of the head and neck region when we start looking at these lesions, but throughout the whole body, with no pain or problem perceived in the mouth. So the physician's not looking in the mouth. If you got a bad pain in your lower back, they're looking gastrointestinal, kidneys, maybe if you're at the chiropractor, they want to adjust something. How many look in your mouth? He states it's generally accepted that surgical therapy for most chronic oral facial pain problems should be restored only when more conservative methods have proved to be ineffective. I don't agree with this. I think it's a waste of money. I had a gentleman come in, 20 years. He lives in LA. He had an oral surgeon try cleaning out his mouth. He had spent tens of thousands of dollars. And I did a 3D cone beam, which I'm sorry I don't have his here today. But Barry has called me up consistently, sending me messages on my phone. I don't believe it. You clean one spot out in my jaw, and all the pain and all the problems, it was tooth number 20 on the lingual side of the plate, which you'd never clean unless you had a 3D cone beam. I'm lucky enough to have a cavitat to show that there was a lot of lack of bone density, but the 3D showed it very well. But I had to clean up the whole left side of his mouth in order to get that clean. And he told me on the spot that the demon was released. And he's calling me weeks later telling me, hey, I can't believe it. I've suffered for 20 years. Who do I yell at? And there's story after story on that. So commonly seen, but certainly not normal or healthy. If we take a look, do we have a pointer? Oh, cool. We got a pointer right here. The multi-ocular construction. Where did you come up with that? Okay, I don't know what happened. Oh, get out of there. It's the spirit of dawn haunting me. All right, so most common lesions are odontogenic, keratositis, ameloblast, large cell granuloma, odontogenic myxoma. So over here, this area is not very solid. So we have to start looking at this. When you extract a tooth, do you see the outline of the tooth? This is where the periodontal ligament still is intact. It's not fully alleviated. The multiocular structures of the third molar indicate incomplete healing. How often have you seen this? The third stage of an ultrasonic imaging of the site. We don't have that, or do we? Let's go back. Oh, down here, I'm sorry. Look at this, shows bone density. I'm going to give a better example later, but there's no bone density there. So the biopsy diagnosis was focal osteoporotic marrow defect, FOMD. You got to always use initials. I don't know why. But it's ischemic osteonecrosis, cavitation. After curettage, the patient's right molar, maxillary molar pain diminished progressively for 3 weeks. I find if you clean it out really well, after they're done healing, within 10 days, 15 days, it all should be gone. But the patient, after 7 years, was totally fine. 2 years after surgery, she developed an increasing pain of the right posterior mandibular and noted a hot spot. The pain disappeared temporarily with a small amount of local anesthetic. If you read Janet Travell's book, Trigger Point Injection, and if we get enough people that turn around and say they want to learn how to do these, I'll do a mini session at my office and do it through the IABDM. And we don't charge a lot through the IABDM. I can show you how to do those injections. They're real simple. And all you do is do 1 or 2 drops. When Dietrich Kleinhardt taught us this, he's German, and he sat there, he says, I know you Americans always like to do a whole bunch of stuff, but all you need is a 1 or 2 drop. And that was it. 1 or 2 drops next to the apex of the tooth or the area that you want to go in. No more than 1 or 2 millimeters deep, and the symptoms go away. You know you can help that person by cleaning that area out. So the patient remained pain-free to the end of the follow-up. So what is an ischemic osteonecrotic lesion? Bone, dead, infected. Pretty straightforward. It's a lack of oxygen. A lesion is a region in an organ or a tissue that has suffered damage through injury or disease, such as a wound, ulcer, abscess, tumor. Ischemic osteonecrotic lesions, Jerry Bocco named it as NICO, and there's a necrosis if it's dead, myelitis if it's pain. So it's pain caused by a hole in the bone of dead or an active infection. Pain is of the face, head, joints, muscles, and may appear as arthritis, fibromyalgia, chronic fatigue, many different degenerative diseases or unexplained diseases. I had one of the best experiences a week ago. A woman came to me after I had treated her. She started in October, I believe, stage 3 breast cancer. Came in, we took a look at everything. And the sad part, how she got to me, was she was sitting next to a patient in an IV room, and the patient said, did you get your mouth looked at? The doctor in the clinic didn't even suggest it. It was the patient sitting next to her. She had been treated for this breast cancer for 2 years. They're keeping it at bay. She came in, we did the full exam, and I'll show you what a full exam consists of in a little bit. And we went in and we removed root canals, dead bone. Of course, first we get started with making sure the perio's good. We make sure that the metals are out, and then we go into the surgical phases. And last week, her cancer markings above were well over 100, and I'm not sure what scale it was. They were under 4. She has everything receded. She's got both her breasts, and she's going to be cancer-free very, very soon by the words of her doctor. A traditional doctor did the last test and said, I don't understand what happened. She said, let me explain. He says, I'm not interested. Okay. Yeah, well, so this stuff can kill you. And it did this gentleman. This is a case thanks to Jerry Boco. This gentleman came in to see him. He was at the University of West Virginia, Morgantown, West Virginia. As you can see, here are the lesions, dead bone. Here's the mandibular canal, and it's all brown. So the myelin sheath is gone. And so what happened, it's like inflammation. It's not so much a disease in its own right. It is a generic process. So the local reaction, systemic or local, the blood flow is gone. Don't use how many of you use epinephrine in your, and don't be shy if you use it. I used it once or twice this last year. The reason you don't want to use it, it cuts off your supply. I'll make you a deal. I've got a replaced knee, my left knee, and I'll challenge anybody in this room to a 100-yard dash, and I don't run too often, if you promise to hold your breath and not breathe. Well, that's what you're doing to these teeth and surgical sites if you're using epinephrine. And please remember that according to standards by the ADA, you're not supposed to use more than 8 carpals of anesthetic because it's supposed to be toxic. So you got to know how much you can use, which limits the amount of surgery you can do at one time. That's why it's good to get an anesthesiologist in because it stretches it a long way. So what happened here? This patient, it came on gradually. He couldn't take the pain any longer. He took a 22 in his mouth, shot himself, wrote a long letter to his family, said I couldn't take the pain anymore because couldn't wear a denture, he couldn't eat, he suffered. And it was all because Jerry went to look at his dental records, and all through his treatment, they always used epinephrine and the bone never restored. So, over here, there is 72 names for the same disease all over the body, depending upon who discovered it or classified it. Especially in dental, they like using their names because they want to be remembered. Jerry got such a great ego that he called it necrotic ischemic osteonecrosis, not Boco's cyst or whatever. And that's what it looks schematically. So, we look at diagnosing ischemic osteonecrosis. Ask the patient to write out their health history if you're going to do this. Either type it out, put it in the record, give you a timeline of what develops. You'd be amazed at how many people get sick after teeth are extracted or root canals are done. Get a list of their supplements, and medications. You don't want people taking vitamin E or vitamin C when you're doing surgery on them because C will cut down their anesthetic, their local anesthetic, orally. Now, if they're taking it IV, that's fine. They can do it all the time during the surgery. And vitamin E causes things to bleed. Aspirin, if they're on an aspirin, you want them off for 1 week prior to surgery. And then you can refer for different things, laboratory tests, thermal imaging, which Dawn went over very well, and a 3D cone beam. Full mouth x-rays, cavitat scan, not readily available anymore. 3 out of 4 studies that went to the FDA for the cavitat I did. One was my dissertation at Capital University. So somebody came up to me and says, Dr. Margolis, you're an expert on this. I said, that plus $5 will get you a cup of coffee at Starbucks. Don't be so impressed. I was very lucky to have known Bob Jones I got to meet Boyd Haley, and he's here, thank God, today. And a lot of these people who started showing how these things are. It is amazing what we know and don't know. But remember something. There was a gentleman by the name of Marjan Seywerd said to question what we learn as a truth in science, because half of what we know today is dead wrong. Think about it. Our main problem is to determine which half. How many people today are using the exact same crown material that you used when you graduated dental school 40 years ago? 30 years ago? 20 years ago? It's all different. It's all different. Periodontal pocketing. This goes to the record keeping that I wanted to do earlier. If you notice, you got to have all these things. You have to have the missing teeth, decayed teeth. You've got to have your periodontal probing. And at the end here, oral cancer screening. How many people are using an oral ID setup in their office? Okay, let me do it the other way. How many are not? I want you to look up oral ID screening. It is a ultraviolet light, and they give you special glasses. And you look in the mouth, and if you see something black, refer them to an oral surgeon. We had a gentleman come in, whole side, right side of his tongue was black. We told him, you got oral cancer, go see the oral surgeon. He's on a 3-month recall. He comes back, did you see the oral surgeon? I've been really busy. So my other dentist in the office called me in, he was shaking. I thought somebody had a heart attack in the chair. That's how bad he was. I went down there. I said, do you have a death wish, or do you just want to be dead? Or would you prefer having half your tongue and throat cut out? Are you that stupid? Now, I don't have a great bedside manner. But you know what? He got out of the chair afterwards. He shook my hand. He said, thank you, looking me straight in the eye, walked up to the front desk, and he got an immediate appointment with the oral surgeon. They checked and saw that he wasn't insured under his policy, and they found a guy, and he had surgery within 7 days. Sometimes you got to take these patients and kick them where it hurts. Yes? Velscope is good. Velscope is great. They had another one where you rinsed your mouth out, and it was vinegar. Yeah, I didn't. That was awful tasting. Yeah. You know how to tell the difference between an oral thermometer and an anal thermometer? Yeah, it's taste. Okay. So you can continue with EAV, Cavitat, other things that you can look at, diagnostic injections. The diagnostic injections are really good. Here's another text. Dr. Robert McMahon did something in Compendium and showed that. And then there's also the neurotherapy according to Hanke. And then the other one, the trigger point injections by Travell and Kennedy. So here's resources that you can go to. So you're damned if you do and you're damned if you don't. I want to thank my friend Wes Shanklin for that slide. So getting to the root of the disease, which is what this whole weekend is named after. Will you treat it or ignore it? Suggest we move to cases. Okay, well, we're going to do that in a second. I got one, let's see, where are we over here? I got one that I kind of did in Reno, and I got a decent review for this. So I'm just going to do one case presentation, and if it bores you, please tell me, I'll stop. Okay, I want to thank Jerry Boco because he helped me do these slides and put them together. I just love Jerry. This is a 44-year-old white female, mother of 8. This experience with my mouth root canal therapy with 13 has been the most excruciating pain I've ever experienced. She had natural birth of all her children at home and was up the same day doing whatever. I go to my regular dentist and they say something about an overfill could be a problem. I go to the specialist who tells me it's no big deal. I had an MRI, seen a pain specialist for my pain. Now the pain is so great, I'm in bed most of the time because I can't function. I'm very sick. I'm very sick. She suffers from dizziness, fatigue, tired at all times, neurological pain, pain of her ears, TM, sinus problems, right side of her neck and head, and asthma. Patient is extremely nervous, anxious, and scared to death. Recent dental history: after DD had root canal therapy on 13, she had pain. 15 already had a root canal with no symptoms. Her general dentist placed a 3-unit bridge, hoping the pain would disappear if she put a bridge on there. Hello? It got worse. The endodontist blamed the pain on the recently placed bridge. Forget the fact that it was painful beforehand. Okay? The general dentist couldn't explain why the pain was not relieved once she placed the bridge and gave her back her money. The endodontist is, I'm not going to say it. Okay, so we look at her. All her treatment is on the left side of her body. Nothing else is there. She had 3 root canals, a few mercury restorations, full bridge. Perio is excellent. This woman, you look at her, she's thin, she's beautiful, her husband's loving, just absolutely very, very devout Christian, very happy with her life. And this is what happened. Right there. That's what happened to her. She had a root canal. She's got all this extra crap everywhere in the area there. We did a cavitat. Cavitat is ultrasonic imaging. If you've never had it done, you take aloe vera gel on the outside and inside of the mouth. You put a transmitter here, and you take a catcher on the inside, which is a 64 8x8 squares that pick up the sound wave. If the sound wave goes all the way through, then it's basically green. If it doesn't go all the way through, then it's interrupted and it's not registered. Very simple technology. So when we look at this, we take these 2 areas here. That's number 1, and that's number premolar. Or it could have been 2. I'm sorry, 1, 2, 3. Okay, so that's 3. This is 1. And then take a look at this whole upper left side. Here's the 3rd molar, and over here is the root canal, and over here is a 3rd molar. Now remember when Marjan was talking, she showed the toxicity on the ALTs. Your 3rd molars are usually more toxic than any root canal that you do. And there's 2 reasons for that. 1, they were taken out when you were a teenager. And how do oral surgeons normally take out your 3rd molars? Well, what they do is they got a clinic, and they get anywhere from 5 to 10 rooms going at a time, and they start IVs, and they got a nurse in the room to monitor, and they get everybody numb, and they keep on going until like 5 rooms are all numb. You go back, you pop out those teeth. You don't want to suture it up because they're going to swell up, right? So don't do that. And then they get taken out of the room, and the nurse cleans everything up, and they do the next 2 rooms. Then he goes back, and there starts the IV, and this keeps on going. That's pretty profitable if you can do 5 to 10 people in the morning at about $4,000 or $5,000 a piece. That's a good production line. I'm not that fast because I do a little more. So when we look at this, I looked at bone density. I looked at what the cavitat showed me, and then I looked at what a 3D shows me. So we went around. First site was up here. The grade was, let's see, let me get my bearing. This was less than 1,500 here on the bone density, and 3 diffuse radiolucency, no pain, bingo. This is a 4, that's a 3. Grade 4, grade 3. So that's how we were able to combine the 2 together. And then over here on this side, you'll see this is a grade 3, 3, 3, and a 4. And down here, you have a whole bunch of stuff, and it was less than 1,500. But the difference with a 3D cone beam is it measures whatever you're measuring. So if I came up here, that's going to be higher than 1,500, but these areas in here were not. And there's a lot of garbage to clean out in there. So if we look at the lower, here you have a grade 3 or 4. This is grade 2. And then if we looked at it, it was also bone density less than that. So what I'd like to skip to is something over here. Say, okay, now this is not my computer, so please don't beat me up. I'm going to try showing you what a 3D cone beam does. This is a great machine. Can you lower the lights at all in here? Make it a little darker, it might be easier to see. You can take this sighting window and you can move it around. And if we look at where the root canal is, I can now take this and blow it up. Thank you. You know, the French always said of the British, when the British said that the empire, the sun never set on the British Empire, you know what the French said? God didn't trust the British in the dark. Okay, I always tell that to John Roberts, who's coming in from Manchester today. So over here, you can see the lesion over here. This doesn't look good. I can't remember. I think this was an abscess too. But over this way, we go in here, and I can come to the side and I say, okay, what is the density? So the density, I can come over here and read the density is 1387. Over here, now that's the tooth. The tooth is very dense. But now we drop down to 1300 down here. If I want to go up to the third molar area here, it's only 1300. That is going to be a soup when you get in there and open it up. Okay? So you have the option of looking at different things. You have the option of looking at the airway. Person doesn't have too bad an airway. She's got some curvature to her neck. The hyoid bone is almost, probably 5 or 15, less than 15 degrees off there. So that's not, you want this to be straight, but this is pretty good. And if anybody asks for symmetry, this was lined up between her upper teeth and her nose, and take a look how far off it is on the spine. So that's always has a lot of fun. So you have all these things to look at. And you can go to the other side, if we can, it's not my computer, so, but this is really a great example of what you can see. This is obvious. Can anybody not see this lesion here? You look at that, the bone density on that, it's got to be, what, 1100? We'll see. 1200. 1400. But it's supposed to be 1550. That's, see, we got a good piece of bone there. You come down here around the bottom of the tooth, you're going to pick up a lot more. And remember, the jawbone's a thick bone, but that's how you play with these. And that's how you can find it. If you don't have a cavitat, you can find that, but remember that it measures everything, so you might not get everything that you'd like to see. Yeah? No. Right, and you're probably on the Hansfield scale, which is the gold standard, and Sirona from Germany didn't use the gold standard measurement, and there is a conversion rate to it. So yeah, that was an excellent question. Again, you guys, you know, it's very funny. Dawn came up to me, and she says, this is a sharp group, and I'm not trying to pat you all on the back, but the fact is that your questions have been excellent. This was a question that came up to me at lunch today. This wasn't even your presentation. But I think that, I know that we have a lot of time. A lot more time than we thought. And when we did this presentation, I thought I could add this. So we'll go through it. If anybody gets bored, you can leave at any time. You won't insult me. My wife leaves the room all the time when I'm talking. So the upper bridge was removed. Root canals 13 and 15 were extracted and opened into an area of ischemic bone in 16, way back here. It was just mush. We added protein-rich fibrogen, and I have a short presentation of that on the end. Anybody using PRF in your extraction sites? Yeah. Great thing. You just have to learn to tap a vein and spin it, and then throw the blood out because that's full of crap. And then you take the plasma-rich fibrogen that has all your healing abilities. There are classes all over for that. And it's definitely adds a lot. My son, the oral surgeon, wasn't using it. I was using it for over a year and a half. And I said, this is what you can charge for it. And this is how you can use it. And this is the benefits. He liked the benefit. He makes enough money. He's not worried about charging more. But now he and his partner, who he's buying into practice, are using it. And they're just praising it to death. It's really great stuff. So it's good for grafting, especially third molars. Take a look at what we've got. Streptococcus mucans, not at a dangerous part. This is from Blanche Gruby's company, DNA Connections. And Actinomyces naslandis. That gets in your lungs, you got problems. That will destroy your lungs. The actinomyces are both really bad for you. One of the things that always seems to come up is Streptococcus intermedius and Gordoni. Sounds like it should be Italian sauce, you know? But anyway, a lot of these are all put together, and this is the big one. The Hep virus shows up all the time. And I honestly, doctor, I don't know what to make of it. We're trying to figure out, but Hep V 58, 39, 16, I mean, there's a whole strand of them. And this is of concern because of cancer. So Rome wasn't built in a day, steady, slow. Due to the patient's health, we decided to do surgery in upper left only. And this turned out to be an excellent decision because she's very uncomfortable and sick for 3 to 4 weeks. And I told her that's what was going to happen. Then she had a complete turnaround day. She woke up and she went, oh my God, there's no more pain. And they moved out of town, came back 6 months later. And she came into the office last week and gave me a hug to tell me that she's doing well. We did the lower, and we still see a whole bunch of very interesting bacterium. The thing that we find that works the best on these patients is IV, vitamin C, glutathione, trace minerals with a Myers cocktail, and ozone, IV ozone. What we have found is vitamin C, ozone, glutathione, and then at another visit, depending upon the doctor, how they do their protocols, you do a Myers cocktail for support. I don't do any of that stuff. I let the NDs and MDHs. Yes? Okay. In this case, what we did when we did the upper, we took the teeth out. And then I removed 1 or 2 millimeters of bone, hoping that I would find the piece that I took out over here. Okay, come on, slideshow. I did a window up there because it was so high up, I couldn't get to it. So sometimes you have to do a window, and then at that point, when I started pulling out the lesion, it just kept coming and coming and coming. I mean, we had enough to fill the size of my thumb with the granulation tissue and everything else. So it wasn't any fun. Yes. I destroyed the Schneiderian, or I call it the antrum, the floor of the antrum. I had to destroy the membrane. It was all entangled. And what will happen is that will heal, but they won't have the little celi on it. It will be more of a scar tissue. But I had no choice. This is what her source of pain was. Yes. Okay. This is how you do it. In your records, you write cleaned socket. That's all you do. Cleaned socket. Now, how do I do it? I generally will take a round burr. I'll go up as high as I can to see if there's already a communication into the sinus, because many times when you get in there, there's already a hole up there. So I go to where I have a feeling of what's there. Then I will step on the register, whatever you call rheostat, and then come up and do the same thing, up or down, depending upon what direction, towards the ridge. And that's how I'll do it. I'll take my time with it, just stroke, light paint strokes. Don't go in there and go voop, because then you'll go right through a nerve or you'll go right into the sinus. You don't want to do that. I'm doing it with a handpiece, a surgical handpiece. I have a foot control. Or today with everything, because you're putting implants in, I'd go to an 800, 1200, or 20,000. Sterile saline. Copious amounts of water. But you just write in there that you've done that. Then when you rinse it with ozone water or hydrogen peroxide. Now, why would I use hydrogen peroxide? Because ozone turns your blood, everything in your blood, to hydrogen peroxide to clean. So I just go ahead and do that. You're welcome. Thank you. All right. So we got to get back to where we were. I usually start with a 10, but I could go on as small as a 2, and 10's usually big enough. So try to make sense of this data. Patient's mouth was divided into 2 or 4 sections, quadrants, possible total of 5 or 6 sections, because we have the fronts. Sometimes we do separately. In most cases, arches are divided right, left, etc. In some cases, the patient being prepared for immediate denture. We divide the arches, we clean out the back, then we make the dentures, and then we two out the front. Biopsy samples are done by a quadrant or section, because you can't charge everybody for every individual tooth. It would cost me $350 to $600 doing the biopsies, because I get histology and I get sometimes I'll get DNA. State board went after me for doing DNA because the CPT code wasn't right, because they didn't have a CPT code for it. Now they do. And in fact, now that we're talking about CPT codes, glad you brought that up, for your oral ID, if you use an immunofluorescence for oral ID of cancer, it's a D0482. You can actually charge out for it. D0482. For decalcification procedures or a histology report, that's a D0475. And of course, I don't have the DNA number with me. I brought the book and I don't know where I put it down, someplace. But if you're cleaning out an osteonecrotic lesion, the new CPT 217 code is D7550. It's partial osteotomy / sequestrum for removal of non-vital bone. So now it's actually recognized by the ADA codes. So removal of loose or sloughed off dead bone caused by infection or reduced blood supply. No, I bill the whole thing out at one time. The girls handle that. What I do on my surgeries is the patient pays for the surgeries. If they get reimbursed, they get reimbursed. You know how many people would disappear if they didn't pay you up front, and then you never get any money back from the insurance company? My service goes to them. Their service is from their service to their insurance to them. The question here is there's a code for cleaning out all by itself. If you take a look at 07110 or 07210, they say in there that you clean out the socket. I don't know the proper wording on it, but I want to keep on going because it's not an insurance course. But yeah, they say that, well, why do you charge so much for it? I said, because we do more. So try to make sense of the data. In the first table, I've named the different histological diagnoses, the diagnosis associated with 2 patients, frequency, and so diagnosis rendered in the case of chronic ischemic bone and viable bone with medullary congestion, oil cyst, fat necrosis, failed root canal, suppurative pulp, meaning that the pulp had pus in it, and hemorrhaging around endo material. So unseen complications. So that just is a little side view of what we have. I'll go back to our regular. I hope I didn't bore you too much on that. Thank you. Here's a case that we did that isn't going to be as extensive, but Diane's a sweetheart. She is a manager at Oasis of Health in Mesa, Arizona for cancer clinics or cancer patients. She had multiple mercury fillings, multiple base crowns, 2 root canals, perio problems, but she wasn't having any problems. She wanted to avoid them in the future, and she just listened to the patients who they had sent over, and so she decided to come see me. This is what her mouth looked like. So, you can see the little mercury and stuff in there. Better view here, root canal there. So we did the charting. We did the perio, just a few spots where you have inflammation. And those are the existing conditions. So 30 had an MOBD, 29 DO, 20 an OL. Composites, pores infused to metal, these things can be dangerous. Whenever you take these things out, has anybody cut off some of these old crowns and it's really hard to cut off? It's crappy metal. It's nickel based, and those things, nickel's carcinogenic. Why would you put it in someone's mouth? But I did that when I first got out of clinic or out of school, because I asked the guy, what lasts the best? It was always the non-precious metals last the best. You can't break them. But they're also the most toxic. Full porcelain and root canals listed. We went through. I happen to use Clifford testing these guys. I love it because it's simple. There's 17,000 different items listed, and it says may be suited, may not be suited. That's simple. I can understand it. Whereas I'm not saying it's better than the other, because Blanche will beat me up. She owns the biocompatible, and they have least reactive, mildly reactive, severely reactive. I like to know if you're pregnant or not pregnant. It's simple as that. So we come here, we look at the initial x-ray, we go in, we take a look at the cavitat, we combine them together, and look, this over to here, here to there, this to there. I mean, it's just a roadmap, just logical. Now, we did have the rest of the mouth, but it took up too much space on the slide. Now, this was the comparison of the density. These were all 3s. And it went, I don't know why he's doing that. Get out of here. So we looked at the density over here, and it correlated with the exception of the root canals. Look at how dense those were. That should be good. No, it's not good, but it measured the density of the tooth and the material, not just the ischemic bone. So this is what it looked like. We did surgery on the left side over here. And let's see, number 3 structure appears healthy. Well, that's a wrong number. We can tell you that. And then over here, we've got what we're looking for. Now, what I love about this, before we get started, I measure from here down to there. I want to know where that nerve is. I've had nerves as high as right underneath the ridge. So when I do that surgery, I know to come buccally, go below, and clean down underneath the ridge, and then identify where the nerve is, and then clean up. But down here, that's pretty safe. That's going to be at least 15 millimeters, if not more. And generally, your burr is going to be no more than 9 or 10 millimeters long. So you're pretty safe with that. We also use a piezo art to cut through the bone sometimes. Then you have the direction of what this nerve is. Take a look at this, how it curves. Many times what you'll see the mental foramen. On a 3D, if you take it and go down the coronal slice, you'll see that this actually curves out. Now, my staff traces this. I go over and check to see if they do it right. And I'll say they make about 35% mistakes on this because they don't get that curve there. And I'm teaching them because then they have to redo it. So, hi, Martha. Everybody say hi to Martha. Martha's in from Brazil. She's wonderful. I'd like you to meet. We want to hook everybody up from their own countries. So if you take a look, Where's the measurement? Oh, that was only 12 millimeters on this one. I'm sorry, looked bigger. And then planned surgery, we're doing the right side. We take a look. I have the measurement. I know where the nerve is. And that's, any questions on that? So that's pre-whatever. So something tells me I feel like I've had the worst job in the world, the toothbrush says, and the toilet paper says, yeah, right. So job's never done until the paperwork is finished. And you got to have your paperwork right. So you got to put in here what you're doing. We've changed all the codes because this is not updated. So this is an old one, and next time around I'll have the proper codes in there. But make sure that they sign it and date it. All consent forms must be unique to your state or province that you practice in. Do not use these forms word for word because it might mean nothing. I recommend using the oral ID Lite, even if the patient is in for surgery or fillings or recall appointments. We will go in and do an oral ID. It takes less than 30 seconds, and we mark it in there. Why do I do that? CYA. 2 years ago, I was talking to an attorney who was representing a dentist, and he had a patient for 9 years. And for the last 8 years, they were watching the side of his tongue. They buried that patient from oral cancer that went undiagnosed, but he was watching it. And the settlement wiped out not only the insurance policy, but the dentist financially. He gave up his entire retirement fund because he killed the guy. Oral maxillofacial, dear patient, you have the right to inform about your diagnosis planning, make a decision whether to undergo a procedure after knowing risks and hazards. This should be given to anybody having a root canal. This disclosure is not meant to frighten or alarm you, it's simply an effort to better inform you. So we go through all the stuff that, this came out of an oral surgery thing, and we redid it and put it together, making sure that people realize that there can be complications because you are human. Please read the following. If you notice, we ask them to initial, and on the bottom of all these things, there's a sign and date. And now we check to make sure that the patient signs the correct date. PRF helps the patient heal faster. It is nothing but yourself. So we take that, you spin it, you go around, and this is what you're pulling out. This is the blood, there's your PRF, comes out like an amoeba. Ozone upregulates your immune system, enhances production of immune based on cytokines, any of the number of substances such as interferon, interleukin, growth factors, secreted by certain cells of the immune system and have an effect on other cells of the body. Ozone's great. Why do people get so upset when they say there's an ozone alert? Anybody know why? They shouldn't be. Well, they should be and they shouldn't be. They should be happy there's an ozone alert because ozone cleans the atmosphere. The only reason it's active and high is because somebody's put too much crap in the air. It's measured in gamma. Rectal is great for ulcers, prostate, Hep C, B. Topical, it's great. If you get ozonated olive oil, there's a guy here, Phil should be here today with his. That's really good stuff. You can inject in the joints. Before my knee was replaced, we used to do that. I used to do it on my shoulder and didn't help much, unfortunately. Took the pain away. So where does it come from? It's created in nature. In nature, ozone created near the edge of our upper space. Ultraviolet radiation coming in from the sun makes contact with ozone in the atmosphere. The energy from the UV is imparted to the oxygen, turns some of the oxygen to ozone. The layer of the ozone is referred to as the ozone layer. Ozone layer is not only created by UVs with oxygen, but it protects the earth, etc. Medical grade, you know the difference between medical grade and regular oxygen when you go get them filled up? There isn't any. You have a different container with a different color, and they fill it up. So the regular stuff for industry is $2. For medical, it's $20. That's the difference. But it contains 78% nitrogen, creates harmful oxides when ozonated. So to use ozone medically, you need to ensure ozone you are using is pure and free of all possible contaminants. Bless you. Only way to be certain of this is to ensure that ozone does not come in contact with any plastic, rubber, metal, ceramics while inside the ozone generator. So you got to make sure you have a good ozone generator in your office. There's plenty of them on the market. Shop it, because there's one that is sold through this convention, and they're about twice the price of anybody else. So different forms of medical ozone. We go into ozonated oils. Ozone is tenfold more soluble than oxygen in water, and ozonated water has a short shelf life. That's one of the problems. Dawn, you can always say so. Would you like the microphone?
Okay. Then that's it's one way for you to get information. So I always tell people, watch the video. If you've got questions, please feel free to email me. Just put in the tagline that you watched the video. You would not believe, all day long I'm answering emails from people who are then trying to get connected with different things, because I don't have a vested interest in what they have done. I'm just really interested in their best health. The other thing that I have on here is, and I spoke to somebody out in the hall about this, you know, I'm really big on you guys networking and building a little group of people that you can send patients back and forth through, so that you get everything covered under what is each of your scope of practice. So one of the things that I had to do, and I always preach about this, is you need to call the office that you're referring to and ask for a CV of the practitioner. And then really do your due diligence and follow up that they can do what they say they can do. I know that doesn't sound very friendly to do that, but I'm going to use my office as an example. I have a guy who refers to me. He's referred to me, I don't know, 15 years at least, and he still does. And I heard one of his patients comment on the fact that he was getting IVs of ozone and that he was getting some IVs of vitamin C. And so then not too long after that, I had a patient who lived, this guy sends people in, it's like a 5-hour drive to come see me for stuff. And he sends them on a routine basis. Well, lo and behold, I have somebody that I'm seeing that kind of lives in that area. And so I'm thinking, well, turnabout's fair play. I should probably refer back to them. Fortunately for me, I did what I preach to people about doing. And I said, hey, you know what? I know you guys, and I've met you in person, but there's a lot of information that I kind of have gaps and holes in. So can I get a little bit of information? If you would believe this, he learned how to do what he does in Mexico at a cancer clinic, and he has no license at all to do anything. And his patients adore him, absolutely adore him, but I cannot refer to him because I'm not going to lose my licenses over a referral. So I'm going to encourage you, again, practice within your scope of practice, and make sure that the people that you are referring to can legally do what they are doing. And you might be surprised. Okay, so ozone, and I just wanted to kind of get into the ozone a little bit. I didn't mean to take this over from Mike, but it came to me as I was listening to it that you guys might get confused about the fact that you could just get an inexpensive ozone generator and be able to do what we do at medical grade, and you can't. And so that, have a really short shelf life of this water. We use ozonated water in the office for everything. We lavage out surgical sites with ozonated water. The hygiene room uses ozonated water. We send patients home with ozonated ice cubes because it stays more stable longer. And ozone can do another cool thing. You ever had a spot in your carpet or some treasured piece of fabric? Ozone will lift out that spot. It's just the coolest thing. So I use ozone ice cubes at home, and I'll drag it out for all kinds of stuff. All right, where did Mike shut me down here? From current slide. Okay, well, this is what I was just talking about. You can't use the room air in order to make good quality ozone. It actually becomes toxic when you're using the nitrogen that's in the atmospheric air. It needs to be produced on site. It's not very stable, so it doesn't You can't keep it for a really long time. And that tubing has to be absolutely latex free. And I'll show you why in just a second. So you guys can read through this about, you know, what you need to say to patients when they talk about ozone alerts. The ozone that you're using in the office is medical grade, so it's a different quality. The ozone that's in the atmosphere, which does have ozone alerts, is because of the nitrogen that's in there. So when we're talking about how it works, well, it's just the coolest thing. It breaks down the polysaccharides of the cell, and so it disturbs the cell wall. And basically the guts, or the cytoplasm inside the cell, leaks out and it dies. And it works on bacteria, virus, and fungus. So, you do want to get trained in ozone. This is not a training course for that. Talking to somebody like Bob Harris and Phil Malika is a great way for you to get trained in using ozone, so that you can legally say, okay, what we're going to do is we're going to put this little stethoscope in your ears, and we're going to be piping ozone through here while the hygienist is working on you. And that might be because a patient came in and they were stuffy and they had a really bad cold, but they had one pocket, remember? Remember I told you earlier, everybody has to have something perio, so you're going to document why you did that. This is basically what the ozone is doing to the cell wall. And this is what happens if you use a latex glove and you're around ozone, which is why you have to have the tubing be non-latex, because otherwise it would just leak out. I am not a big fan of what ozone smells like. It just drives me berserk. When you guys come to my office and we do a weekend course of this, and we're going over, this is how you turn on an ozone machine. This is what ozone smells like. Let's take a slide on this gnarly person and look at it under here. Oh, let's ozonate one quadrant of this person, and let's take another sample and put it under the microscope and see what happens. It's amazing, absolutely amazing. But when that ozone is running, I am just running around with my nose pinched because it just drives me crazy. Can't stand the smell. But there are lots of different uses in dentistry legally for you to do. So you can do the prolotherapy, the ozonated olive oil. We'll have some different vendors here that have ozonated olive oils that you can use. Direct injection into the tissues. Using it for your waterline disinfection is a great way. Desensitizing teeth. Oh my gosh, if a patient comes in and they've got a sensitive tooth, you are their new best friend, because you can just take it away like that using the ozone. And of course, arresting decay. If you've seen some of Tim Rainey's work where they're using ozone, Tim Rainey did this really cool course down in Belize where they took kids that were indigent, and they ran them through a clinic there that they were providing services for. And what they used was air abrasion to blow away the decay, and then they used ozone to go ahead and arrest the decay that was there, and then go ahead and put a sealant in. And this wasn't for every tooth that they could do this on. But the idea was, this is what you can provide in an indigent area without having to have a drill or anything else. Of course, and periodontal disease reversal and control of it using some of the ozone trace. So the ozonated water is really potent, and it does oxygenate the tissues, and it doesn't leave a chemical residue. And you want to use it at 4 gamma, which is the minimum dose. Applied for about 10 seconds, and that bacteria is gone. And if you have a microscope, do this. Matter of fact, we have an outlet for you guys to be published. The IABDM has an online journal. So if you want to do some small research project and then submit it so that it could be peer reviewed, then you can be published. I would welcome you doing that. This would be a perfect opportunity for a hygienist to take 4 cases, document what the bacteria is before, do just 1 quadrant, doesn't have to be full mouth, and then use the ozone and show what the bacteria did afterwards. You're going to be just blown away. Here's treating the dent. Yes?
How do you document what the bacteria is?
On the slide?
Oh, you got it on the slide?
Yeah.
Dental DNA is
Yes.
flawed.
Okay, and yes, and you could take it to another level. You could do salivary testing on them and submit that sample, not send it in yet. And then you could ozonate them, and you could send in another sample just to show at different levels. I was just talking about from looking at a microscope, but yeah, you could take it to a whole different level. So the ozone therapy can be applied subgingivally, and if you've seen it before, the tubing comes off of the unit, and it's got a little, it looks like a needle, but it's blunted, so it's a probe. And you insert it subgingivally, and it starts blowing bubbles. It's pretty cool. And that's how you know that it's working. And you just kind of slide it along. So if you've ever taken a laser course before, it's about that same speed that you're just kind of sliding along. And it's just nuking all the bugs and bacteria that are in there. You can use the ozonated water in your Cavitron, which I don't think it's called a Cavitron anymore, is it? Oh, is it? Okay. Well, I thought they had something else. And then those ozonated oils can be used topically. A lot of them taste really nasty. They're thick. There's one, olive gold. It's not as thick. So for me, it's about the texture. So that's another option of something to use. It's ozonated. And so here is just using the ozone in a hygiene visit in a Cavitron. You could get real involved and use these custom trays. They're a little spendy. I think it's a couple $100 just to have the trays made. But then the patient keeps the trays and they come back in for the visit. You connect it and you're able to ozonate, and it looks like that. And they just kind of sit there while they're chugging along. They don't have to sit for very long, but it's isolating the ozone to the gingiva in that area. Treating an aphthous ulcer, another thing that will just make a friend for life. Somebody comes in and you know how sore those boogers are, and there's nothing that you can put on that takes away the pain like that. Yeah, it does when you ozonate it. So just drag it out. It's almost like when you're using a laser and you're able to provide that kind of care for somebody. And then using the ozonated oils daily can help with those lesions. And there's a before and after just to show you how quickly it heals. Yeah, I mean, you're talking about a viral load, and I mean, who wouldn't want to have that? So the research shows that the caries incidence is reduced at 24-month mark with 10 seconds of ozone applied. This is not something that's going to take a lot of time. It is going to take a high-quality ozone, though. Again, it's medical-grade ozone. You're not going to get these kind of results by a little ozone generator that uses that atmospheric air. When you're looking at applying it to a tooth that's sensitive, 2 to 3 minutes reduces the sensitivity to near zero. Using it in the lines to help reduce the incidence of Legionnaire's disease. Everybody remembers that 60 Minutes show from some time ago that showed how nasty the water coming out of a dental line was. Yes. No, anything that's latex, it will. But that plastic, I've not seen it, not in ours. Have you? No. Okay, question. Different lines for cleaners? Oh, no, this is the water that's going to the patient, not the stuff that's coming suctioned out back into the, that's a good question. I like that. Okay, so then you have some patients that are really sensitive to the, their breathing, like me, I'm sensitive to it. If I'm around it for very long, I'm going to start to cough. In order to undo that, you just have some vitamin C that's chewable around for them, and it will help the irritation. In Germany, there's a report that says that 5.6 million ozone treatments had 0.00007% side effects, with 0 deaths reported. Compare this to drugs in the U.S., 140,000 deaths from prescription medications in 1 year, and 1.5 million people hospitalized from pharmaceutical side effects every year. So it's pretty safe stuff to use. Yes. Okay, so are you going to go back with the oil pulling? Are you ready? Okay, no. Yes. I have not seen anybody say that it harms the composites in any way. Great question for Phil, when you're taking a class. I mean, it's a wonderful class if you've never taken that and there's 2 levels of it. So at the beginner class, you're overwhelmed. And when you get into the advanced class, you're really, really overwhelmed because at that point, you're doing trigger point injections of all kinds of stuff. But it's very worthwhile. It's an expensive class, so be prepared. But I don't know anybody that's taken it that's not said it's been worth full value. Incredible. Okay, so when we're talking about oil pulling, oh my gosh, I remember years ago where a lady came in and she was telling me she was doing oil pulling. I had no idea what she was talking about. And yet, we were doing oil pulling when we were talking about doing castor oil packs. It's just that I wasn't thinking of it in the same light. So oil's been used for thousands of years to try to get toxins out of a body. And now there are people that use coconut oil as well as the sesame oil, and there are other oils that can be used. You know, the downside is you have to swish it for forever, 10 to 20 minutes, and it is so gross when you spit it out. And if you're dealing with some of the oils, they not only taste bad. I gave you some samples of some that I hope you contact the company and at least say thank you, because they just contacted me out of the blue and said, can I send samples? And I said, hey, you know what? We're getting ready to lecture at a meeting where I got a bunch of dentists and hygienists. I'd be happy to hand them out. So you can contact them directly. Yes? I'm not so sure that I have seen it on the microscope because I have not been the one looking for that. I have seen tissue improvement as far as the amount of bleeding. Now, whether that's just the mechanical action of somebody swishing, I don't know. Or whether it's actually taking something out of the gingiva itself that's toxic in nature. But that would be a good small study to do. That would be a really good one to do. Okay, so, yes.